Hello, my name is Miriam Peralta Carcelin. I am a professor and a developmental pediatrician, and I work at UAB at the Department of Pediatrics. I'll be talking today about developmental screening and focus some on the science and tools for performing developmental and behavioral screening. I have no financial interest, and I will discuss some commercial products or services. However, I will not intend to discuss any non-FDA approved uses of products or providers of services. A brief overview. I will go with some introduction about the science of developmental screening, and I will review some of the screening guidelines and some of the tools that will be recommended for use. So why are we doing developmental and behavioral screening? We know that 20% of all visits to pediatrician's office are for developmental and behavioral concerns. And many times the parental concerns are correct and accurate. And we also know that 16% of the children in general have disabilities, including speech and language delays, intellectual and learning disabilities, as well as emotional and behavioral problems. And we do know also that only half of the children with disabilities are identified prior to the school entrance. And by the time that the children enter kindergarten, you can actually predict school dropout rates with about 70% of accuracy, which means that you had lost those first 5 years of life for detecting developmental disabilities. Now, what about autism spectrum disorders? The CDC reports that there is 1 in 68 children who will have the diagnosis of autism spectrum disorder. The age of diagnosis, though, is not made until 4 years of age. However, we do know that a third of the parents of children with autism, they noticed the problem before the child was 1 year old, and 80% of the parents had already seen problems by the time the child is 24 months old. Therefore, early detection is crucial for autism spectrum disorders because there are interventions available. Now, the importance of development and surveillance and screening in very young infants and children have been addressed by the American Academy of Pediatrics, and they had developed a policy that has been reviewed several times, the last one being in 2006, and is currently under review as well. And the reason the AAP policy was addressed is because it's important in the primary care setting to do developmental screening in children, that usually children are in contact with pediatricians and healthcare providers, and actually maybe the best informed professional that they will have contact with. And also we know parents look at their pediatrician as an expert in child development. We know early intervention is available and effective, and also screening instruments have improved. Now, since the AAP policy, there had been several surveys whether pediatricians are using screening tools. And it has increased in the AAP survey in 2009. 47% of pediatricians reported using a standardized screening tool. And actually the rates have increased now. The last report was given in 2016, and this has increased to 63%. However, there is still 47% of pediatricians who do not use a standardized screening tool. Now, for Alabama, I don't have more recent data, but the 2010 data show that only 32% of children in Alabama were screening using a standardized developmental screening. This is just to show the increase of screening from a previous survey done in 2002 and then in 2009, and the type of screening instruments that they use. The Ages and Stages questionnaire is used very frequently, as well as the parents' evaluation for developmental status, which is called the PEDS. And we'll review this later as well. Now, as I mentioned before, we know 99% of children, of young children less than 5 years of age, are seen at the pediatrician clinician. Some children are not seen by nursery providers, which will be another healthcare professional who has expertise in child development. Only 50% attend nursery or preschool. So, what are the detection rates when you use a standardized screening tool? If without screening tools being used in the pediatrician office, the detection rate is only 30%, and that increased significantly when they use screening tools to 70 to 90%. Same for mental health problems. If without screening tools, pediatricians are only able to detect 20%, and when they use screening tools, they are able to detect 80 to 90%. Many pediatricians are still reluctant to using screening tools. However, there was a review for when physicians use their own homemade checklist, and that their sensitivity for detecting developmental problems was somewhere between 14 and 54%. Their specificity was high. However, they missed a significant number of cases. Now, can it be implemented in the practices? There are several studies that have looked into this, and does it have an effect for referring children to developmental evaluations or interventions? This study showed how after implementing a developmental screening, the practices has significant increase on referrals. Now, this same study compare how the pediatrician did in detecting delays versus just using the screening instrument, and you can see that the pediatrician detected about 10% of the delayed children, and whether the ASQ detected 21%. This is just the same study. It's a little bit unclear to see, but basically what they did is they showed the pediatricians, there was a large number of children involved, 1,400 children, and the pediatrician evaluated the child with their own checklist or their own knowledge, and they refer with the ones that they suspect they have developmental disabilities versus the ASQ, which was administered to the same group of children. The parents responded to the screen, and the ASQ actually was able to detect better than just the physicians alone. And these children were referred, but not just referred, but they also had more. They qualified for early intervention, so they had true delays. So the question is, are we meeting the needs of our families? You know, we in general as pediatricians like to be in the business of developmental assurance. It is difficult for us to say your child, has some delays. However, we need to make sure that that the families and the children especially are referred timely because of their brain development in early childhood. Before I go more into the screening instruments, I would just like to differentiate of what is called, at least by the AAP policy, surveillance, screening, or evaluation. So surveillance usually refers to a flexible, continuous process in which professionals, in our case, pediatricians, perform skill observations of children during the provision of child health care. So this is what you do at every preventive visit. You inquire about how their development is. Some people use some checklists as well. Now, screening refers when to using a validated test that in general has to be brief and objective. And the goal of screening is to detect children who are probably doing well and those that need additional investigation. It does not give you a diagnosis. And usually is performed at a set point in time in all children, including asymptomatic children. And the evaluation, of course, is the more in-depth, comprehensive examination. Usually requires a referral and usually is to give a diagnosis. So for surveillance, in order to be effective, you need to elicit and attend to parents, ask them questions about development. And the more important part of this is listen to what the parents have to say. Now, you also want to make sure you document and maintain a developmental history of every visit. And of course, as pediatricians, you learn what development milestones the child should be reaching at certain ages. So make sure you review this. You have to have skillful observation of the child. You also want to make sure you identify risk and protective factors, and I'll go over this in the next slide. And more importantly, you need to share your opinions with other professionals. Sometimes daycare providers may give an input about what they're concerned about, or if you are concerned about something, you can inquire from the school, and so on. So risk factors. What are risk factors for developmental delays? There are biomedical risk factors like prematurity, prenatal exposure to drugs, alcohol, having some type of genetic disorder, feeding growth, exposure to lead or any other toxins, or having a family history for developmental problems. Now, there are also social risk factors. Children who don't go as much to your visits, they miss appointments, whether they are in foster care, poverty is a huge risk factor, international adoption, parental depression, and mental or other mental illnesses, having a teen parent, and of course exposure to toxic stress, and child abuse and neglect. So it's important that you inquire about these risk factors. Now, in order to when you do your skillful observation, remember your red flags that you may look for. For example, if you have a baby who is 6 months old and it's not smiling or having any kind of joyful expressions, doesn't have any forced sharing of sounds, smiles by the age of 9 months, requires a referral, not babbling at all by 12 months, not responding to name, no words. And this is just a few examples. And of course, very important is any loss of speech, babbling, social skill, or any other area of development, including, motor development at any age, is a significant red flag that needs an immediate evaluation. Now, the screening, of course, comes with some challenges. For providers, they report that they have resistance to use screening tools, and sometimes that is because of lack of knowledge. That usually they expect normal development, may not have had the training necessary. We like to wait and see very commonly. However, it is very important that children at this age receive intervention and evaluations as soon as possible. As I mentioned before, brain development is very rapidly in the first 3 years of life. Some, even when they're positive, tend to ignore screening test results. And they go back to their own skill observations. Some pediatricians report, I can tell when a child is delayed, which have shown in some studies that some I mentioned previously and some more recent studies, can be very difficult in a 5-minute visit or 10-minute to detect developmental delays. And some rely very much on their own tools or checklists, which actually have not been tested for quality or validated. Other challenges reported by providers is that they don't have time to do this, they don't have staff, they don't get reimbursed, and there's some parents that can be difficult. They may not accept developmental delay or that they see even a problem. And these are valid challenges and concerns. Now, with parents, of course, there are some concerns as well. That it could be that parents may recall inaccurately, that interpretation of some questions may be difficult for some parents. Most of the screening instruments are done at the 4th, 6th grade reading level, but there's still some literacy problems or other languages. And maybe parent has a problem on their own. They may have depression, so they don't really give a reliable report. However, screening has significant benefits. The main benefits is you identified early any kind of developmental or behavioral problem. Like I said, we have the young brain development, which is happening rapidly. And this is an important time to act. And we also know that intervention studies show that the outcome provides better intellectual, social, and adaptive behavior. There's more high school education, employment rates, there's decreased criminality and teen pregnancy. And also we know that the patient and family satisfaction with the provider improves and also meets some of the legal requirements for some of the insurances. More benefits. Even though we have some challenges with the parents, however, parents can provide a lot of information of their children. And also the screening test itself becomes a teaching tool, and the observations are more structured, and same as the reports and communication. And if we use a good standardized instrument, it can reduce the unreliability of the parent's report. So when you select a tool for screening, there are problems that you need to address, right? The technical problems, is this instrument valid or reliable? Is it practical? You want to know the cost of the instrument, how much time it takes, how convenient it is to administer. So there are several tools that may comply this for detecting developmental and behavioral screening in young children, which are listed here in this table. Which includes the ASQ and the PEDS, which are the more frequently used, and of course for autism, the MCHAT is more frequently used. Now for this project, we intend to use the Ages and Stages Questionnaire 3, which is done at 9, 18, 24, and 36 months as recommended by the AAP. And then we also intend to use the ASQ-SE at 36 months or as needed. And same for the ASQ-3, it could be as needed as well. And the MCHAT is recommended to be used at 18 and 24 months. Now, what is the ASQ-3? The ASQ-3 actually was developed in 1999 and includes several areas of development, which includes communication, growth, fine motor, problem solving, and personal social. And it has the added questionnaire, which is the social and emotional development, the SE. And now actually they have a new version that is called ASQ-SE2. The parents, you can interview the parents or they can fill the form. Most of pediatricians find more practical that the parents fill the form. It is very easily readable and does have pictures in it that helps. And it goes, you can use it between 1 and 66 months. It does come in Spanish and other languages as well. And another advantage is that the cost is one time and you can photocopy as many as you need. And also has a version to be used in the computer or the internet. Now, to explain the ASQ, how it's administered, I'll just go through a case study. Miss Smith, for example, brings Andrea for an 18-month visit. And this child is new to your practice. So it's a preventive care visit. So what do you do in the preventive care visit? You do surveillance, as I said before. That means you ask for developmental problems. Now, before, of course, you review, this is your first the first time you're seeing this child, that we know she is new. She was full term, normal birth weight, received a little bit of oxygen at birth, has had several episodes of otitis media, otherwise has been pretty healthy, is in no medication, has her immunizations, has had no prior concerns on development, no problems during previous medical problems besides the ear infections. Mom is a 25-year-old. She's a single mother. She works full-time, and there's a father who is involved, and they're both high school graduates. Family history, there's some cousins with speech delay, and the father is reported to be a late talker. So this is your reviewing your risk factors and protective factors. So you go and ask the questions about concerns about her development, behavior, or learning. And mom says, well, that she's worried about her talking. She seems to be behind other kids her age. And she noticed that at the playground, other kids are saying real words. However, she's only saying a couple of words. And then you ask further questions about whether she can understand. And mother says that she hears fine, and she does not sure about understanding. So then you ask a little bit more, how does she communicate, what she wants. She asks you that, she tells you that she may say single words, or she may start crying until mom is able to figure out what she needs. Does she point? You use some questions, some probing questions, and she says, no, I don't think she points. So this gives you some concerns at that time. But while you're talking to the mother, of course, you are doing your skillful observations, and you're observing Andrea, who seems to be interested in playing with the toys. As she plays, she does look at her mother sometimes, and she shows her mother some of the toys. She's interested in playing with the wheels of the car and tries to engage with mother. She does have eye contact, but this is fleeting, and she does respond to her name. However, her speech is immature jargoning. So given that you perform surveillance, you have some concerns, right, on development in this case. And also is a 18-month visit, which is recommended to do a standardized developmental screening. So in either case, this child needs to have a screening tool administered. So this is where you use your ASQ 3. And the ASQ has different parts, different areas that it covers. One of those is communication. And I'm just going to go through Andrea's responses and how you do this. Usually there are 3 options: yes, sometimes, and not yet. And for each option that they answer, if they say yes, they get 10 points. If they have sometimes, they get 5 points. And if it says not yet, they get 0 points. So in her case, regarding the questions of communications, she only answers this question number 2 and gets 5 points in the area of communication. And now in other areas like gross motor, she's doing this pretty well in general, so she gets this score, 55. And then in fine motor, she also does pretty well. She gets a score of 55. Problem solving, doesn't do as great, but she does get a different score. And then there's a section where they can report, handwritten, what they're concerned about. And in this case, she reports that she doesn't play with other kids, and she seems to not connect with them as well. So after you score all those areas, you can put them in the first page where there is a graph that looks like this, and then you will mark an X where the number is. And there are 3 areas in the form. One is a dark area, there's a white area, and there's a gray area. And when you look at the results of this child, she fails on the area of communication, and is borderline on the area of personal, social, and problem solving. So you reviewed the results, and like I mentioned, she failed the communication domain, and there's a suspect because that's the gray area on the personal, social, and problem solving. What other screening should have been completed at this age as well is the autism screening. We said 18 and 24 months. So for autism screening, the AAP also has some separate recommendations. However, their recommendations are based on family history, that you should do it every visit, especially if they have another child in the household that has autism, if the parents are concerned of autism, or others like a daycare provider is concerned of autism, or if yourself has seen some signs of autism. So it's important that you look at these areas and administer screening according to this. Now, the AAP recommends that all children should be screened at 18 months and 24 months with an autism-specific screening tools. There are not too many reliable screening tools for the young age, and for this project, as I mentioned before, we're using the MCHAT review. And it's actually just 20 questions, and they have 2 options, yes or no. And it measures social reciprocity, language, and even some motor abilities. It can detect more than autism, can detect language impairment, intellectual disabilities. And one of this new revision of the MCHAT, it gives you a score, and you can be assigned to be low risk, moderate, or high risk for autism. So it depends on the score that you receive, and I'll go a little bit over an example, that you will either administer a follow-up interview or not. So the score is very low, 2 and less. They don't, it's a very low risk, so there's no need to do anything further except to keep monitoring. A moderate risk is 3 to 7, and that's when you need to administer the follow-up interview. But however, if the score is over 8, then you need to refer for an autism evaluation. The other advantage of the MCHAT that it's free to download. It takes 5 minutes, and even though it says translation now, they do have translation in Spanish and some other languages. So it was, has it been applied to practices and see if it's effective? Well, Robbins did a study, who is the author, in 2014, and look at parents of toddlers between 18 and 24 months, and apply the MCHAT, and those that failed completed the follow-up interview. They also did diagnostic evaluations of those children who screened positive, and they had a random sample of children who screened negative, who were also invited to receive a complete assessment for autism. And what you found is that the sensitivity of the MCHAT to detect autism was 94%, the specificity 83%. So it's very important, it's a good sensitivity and specificity. And also the positive predictive value, if you only use the MCHAT, is very low. However, if you use combined, it's higher. And if you look for not just autism here, but for any delay, the positive predictive value is very high. So it's very important that we use the autism screening. The 2-stage level is helpful. And also she noted that when the physician was concerned about autism, only had a sensitivity of 24%. And these are just some websites where you can download the MCHAT as well as the MCHAT scoring form. Okay, so back to our example, Maria. She is 18 months. Mother answers the MCHAT, and these are her responses. Now, how do you interpret these responses? Well, most of the 20 questions, all of them are the correct answer is yes, except for 3 questions. There is 2, 5, and 12 questions. In our case, this child the mother answered incorrectly 4 questions. So that means that she gets a score of 4. So we had said previously that if the score is between 3 and 7, in our case is 4, that means they need the follow-up interview. And then we'll rescore depending on how they answer the follow-up interview. The follow-up interview is also free from these websites. The follow-up interview has specific questions, and you only need to administer on the questions that the child failed. And it has more specific questions. It's very easy to administer. You need to have just somebody that's trained. Some people do it in the same visit office. Some people use a phone call to the parent to use it. But after that, you rescore. And once you rescored it, then you're able to put it again in that form that you have. And then after the interview, so we administer these 4 questions, they either continue to fail or we clarify better and they pass. So with the new score, she actually has now a 2. And according to our algorithm, if it's 2, then they don't need follow-up needed. So the final screening results for this child was, as I mentioned before, the ASQ3 concerns communication and suspect on problem solving and personal social. And the MCHAT had a risk score of 4 with just the MCHAT. With the interview, had a risk score of 2. All right. So screening actually can sort children in 3 categories, basically. Ones that they need additional evaluation, ones that need close monitoring, and ones that need ongoing monitoring in the context of well child care. So these are children who pass the screening test. So in our case, this child failed the communication area. So that needs to be addressed. Also, in order to guide decisions and how you're going to do your referrals, you need to assess, again, risk and protective factors that I mentioned before. Protective factors, for example, are support, family support, educated parents that provide resilience to the child. We already went to some of these factors. And of course, you want to know about the developmental history, not just take the screening alone, but also find out what is the context. If this child was premature, was this child had any other risk factors. Now, the follow-up referral criteria, we said refer for diagnostic assessment. There are different places where you can get help. One is the early intervention for less than 3 years, the Child Find, and also the local school systems as well. And the services are provided free for the families. Now, you also want to look at what the part that they feel. If they had any concerns, make sure you respond to all the concerns they have. And I know we have certain age where we do this screening, but however, if you have concerns at another age, you can also screen as well. Now, how do you communicate the screening results? Because it's difficult, So you need to make sure to assure the family that the discussion is confidential. Explain to them, why are you screening? Avoid terms such as pass, fail. Instead, you could use below cutoff or near cutoff or at risk. Review with them and explain them the scores. Emphasize their strengths that they have in the family or the child. Tell them what the concerns are and give them specific examples, and invite them to share their observations and or concerns. And you want to prepare for the meeting. You want to make notes of the behaviors you want to tell the parent. You also want to take notes of what you need to gather in addition from the family. Make sure it's private, of course. You also need to consider the cultural and language issues. And you want to know your community resources. And more than anything, be calm. Some parents may react differently. So you review the results of the screening test with the mother. So you said, based on our conversation, as well as the results of underage test screening, I'm concerned about address development. So try to use a language that encourages follow-up and avoid negative and meaningful words. So going back to our case, we have done the surveillance. We had administered a screening tool because we were concerned, and also because it was a visit, preventive visit that is recommended to administer a screen tool. Now, after we administer the screen tool, we look and review the results, and if there are no concerns, when we continue to follow the patient in their preventive care. And however, if there are concerns after the administration of the screening tool, then we go to further evaluation, some of the medical evaluation, developmental evaluation, and referral to early intervention. Now, if after the developmental evaluation and medical evaluation there are no concerns, then we'll continue the routine visits. However, if the developmental evaluation shows that the child has a diagnosis that needs immediate attention, you will follow this child as a child having a special healthcare needs, and you initiate chronic condition management. So one of the other areas that we want to include in our quality improvement is the screening for social emotional development. Although it has not been specifically mentioned in the AAP guidelines, we know it's important to look into social emotional development, because we know that about 20% of children in the U.S. will have a behavioral or an emotional disorder at any given time. And we also know that for a child to develop healthy, they need to have a healthy social and emotional development, because it's the foundation for promoting all other domains of children's development. So the children's development does not progresses in an isolated context. It's actually a dynamic transaction between their biological, their genetic tendencies, and their life experiences. So during the first 18 months of life, social and emotional areas of the brain are growing significantly and actually developing even more rapidly than the language and the cognitive areas. And the quality of the early social and emotional experiences that a child has will have long-lasting implications, not only on their development, on their learning abilities, cognitive, but also has physical health consequences. So same as other areas of development, there is a social and emotional development milestones that I recommend that you have this in your office to look at what is it a child should be doing at certain ages, just like we look at the motor part. Usually by 12 months, the child is able to show objects to the parent, and later will show objects to the parent just to share enjoyment. At 7 months, he looks from object to parent and back when he needs help. He also is able to respond to their name pretty well at an early age. So all of these things are important in order to do the skill observations of the child. Now, this is just to continue, 18 months, they can do some pretend play. By 2 years, they usually do parallel play. And then, and by 3 years, usually they're sharing without prompting. They have imaginative play, uses words. So this is important to look at as well. Now, but there are also red flags in the social emotional development. If by 6 months a child is not smiling or has any other joyful expressions, they need referral immediately or further investigation. Or they don't have any reciprocal interactions at 9 months, like playing peekaboo, pat a cake, and so on. Or if by 12 months they don't respond to their name, that is a significant concern, or they're not showing as well. So that's very important that that you keep this in mind when you're looking in the preventive care and performing your surveillance. Now, the instrument that is being recommended for this quality improvement project is the ASQ-SE, which is part of the ASQ-3. And like I mentioned, currently we have the ASQ-SE2, which is very similar. It's designed to be answered. It has a lot more questions, though, and it actually has 3 answers for this. And it has a good reported sensitivity and specificity. And we want the caregiver, whoever responds the questionnaire, to have at least 15 to 20 hours in contact with the child. So it can be used at different ages. Not as many ages as the ASQ-3, but it doesn't take but 10 to 15 minutes. Then I just want to point out there are open-ended questions at the end, and please don't ignore this. Don't just use the number, because this is where usually parents will answer the significant concerns they have that they may not tell you directly. Has 7 areas that are addressed, which is self-regulation, which is the ability and willingness to calm, to settle, or to adjust. Compliance, ability to conform to the direction. Communication, adaptive, the ability to cope with physiological needs, autonomy, affect, and interactions with people. It also addresses the competence and behavior problems are targeted. For example, competence will be, does your baby let you know when she's hungry, hurt, or wet? Does she like to be picked up and held? Behavior problems, if he hurt himself or on purpose, or eating problems, etc. And also externalizing and internalizing behaviors are targeted. It is published by the same company, of course, that uses the ASQ-3, and it is available in English and Spanish, and I think other languages are now available. The scoring is a little bit different than the ASQ-3 because it has 3 options most of the time, sometimes rarely or never. So it has a series of questions, and they are not exactly in order, so they use this XVC in order to score it. So the X usually refers to 10-point scoring, the V is 5 points, and the Z 0. And these letters will be here next to the box where they respond. And there's also another column, which is if this is a significant concern with the child. And the parents will answer that. So that gets 5 points. So you add all these points, and then add the points and put them in the front page, and it gives you a score. And they always gives you a cutoff score. If the score is higher than the score that you have here, then that means that this child is having some social emotional problems. So same thing, if you find that the score is higher, you want to discuss with the parents, discuss the items that individually score 10 or 15 points. Definitely the concerns of the parent as well. The cutoffs of the ASQSE are very different than the ASQ3. And of course, we had mentioned this before, that we have to look into several factors in order to do referrals. Sometimes there are questionable scores that you may have questions about it, that it doesn't seem to be right. You may ask another caregiver, or you can observe the child itself and have somebody else administer the tool. And of course, same question, if the child is below this cutoff score, then it's probably no further evaluation necessary. However, if it's above the cutoff scores, then look at other risk factors, as I say, but it puts the child at risk for social-emotional development. And the possible follow-up could be depending on the information that you gather. You could be the person providing the follow-up. You may want to do some education and support, or perhaps you need a referral or in some local community agency, church groups, community groups, parenting groups, or refer to Early Head Start. And depending on what you find on other risks, you may include a mental health evaluation. Now, this is just an example of how the new ASQSE looks. It's just a little bit different, like I said, but cutoff scores have been set up, have changed. And I had mentioned before the ASQ3 about how you communicate the screening results, and the same applies for the SE. So where do you refer when a child has developmental screening problems, behavioral problems, and so on? There are some specialty clinics around that for further assessment, like the developmental clinic, medical autism clinic at Children's. There are other clinics like SPARS clinics. There are several providers that can do OT, PT, speech, hearing, and vision. Some of the cases, especially if there's any regression, you may need to use neurology. And at the same time you're referring for further evaluation, you want to refer the children for early intervention or the school system, depending on the age. If it's 3 or less, they can be seen by early intervention. And if it's above 3, the school systems will do the evaluations and treatment. Help Me Grow can be another resource that you can use for help. So in summary, surveillance and screening for developmental and behavioral issues are a very important part of the pediatric visit. The decisions about referral or follow-ups should be based on the results of your screening. However, you need to consider other risk factors present, as well as protective factors. And you can start the medical evaluation for children at your office or a return visit. You could, for example, you could refer them to get a hearing assessment. And it's important that the children get referred as well, not just for the evaluation, but for early intervention, special education. And it's very important that you know your community resources. So thank you very much. These are some samples of internet resources. And if you have any questions, feel free to email me. There's my email. And please complete the process for CME going back to post-test and evaluation.